Yeah, good morning. Thank you for the invite. So, how do I fix my grafts in ACL reconstruction? Hamstring, bone-patellar, tendon-bone, quads. So, what do we want to achieve? We want something that's simple, reproducible, biomechanical, cost-effective, amenable to revision surgery. What do we want our graft, tunnel, and our fixation to achieve? We want early stability to allow early rehabilitation, accelerated rehab in the right group. We want to promote graft, tunnel healing. What do we want to avoid? Immediate slip, early slip, micromotion, tensile forces, shear forces, and potentially that third space with synovial fluid infiltrating the junction between your graft and the tunnel and delaying incorporation and healing. You've got a lot of choices now. We have a lot of choices. Suspensory, single, double, adjustable, fixed, screws, titanium, biocomposite, bioabsorbable, PEEK, you can use a post. You can go press fit. Never done it, never seen anyone do it, but interesting looking at a few articles. And a secondary fixation, suture anchor, staple, or a post. And there's your variety there as well. Grafts, as mentioned, all soft tissue, hamstring, bone-patellar tendon-bone, quads, the option of a hybrid, all soft tissue, or a bone plug on one side, soft tissue on the other. So, what do? Hamstrings for me, quadrupled still sometimes in the adolescence, but generally I'm a semi-T, gracilis, M5 or M6, adjustable button on the femur, titanium screw on the tibia, and a secondary suture anchor fixation. That's my hamstring choice. Now, bone-patellar tendon-bone, my preference is titanium RCI. They didn't have it on the shelf of our new elective orthopedic centre. I'm not going to cancel the case, but I can't tell you here if I used a biocomposite or a PEEK. And I think I know where the tunnels are. Not sure. And then quads, I've moved a bit away from quads. Quite liked it for some of my multi-ligament needs, but their knees, and that's a double suspensory for the quads. Interesting about the role of potential and interference screw for your quads if you go for a longer length. As mentioned, if you've gone for the 60, you're 20-20 in your two sockets, so you've got to go suspensory. If you can get to your 70-80, you've got the option for an interference on your tibia. So, science, quite heterogeneous if you really look into it, to be honest. We can be a bit influenced by the industry. I think it's very good to do these talks. You can go through the literature yourself again and convince yourself what's good, what's bad, and are you doing the right thing for you or the right thing for your patient? Currently, I think some of the graft choices do dictate your fixation. If you're going for a quadrupled semi-T, you're going suspensory. And I know there's some of the clinical studies coming out, but the biomechanical studies, there's not a lot, small numbers, cadaveric, so I think look at the evidence. And again, every time I do these talks, some people think it's old-fashioned, but what's your gold standard? Bone block, aperture fixation with interference screws, titanium, and I think quick, win, cheap, doesn't take you long in theatre, a secondary suture anchor fixation to prevent that early slip. Thank you very much.